Okay, I'm sure a lot of you have had opportunity to experience with EHRs. How many have experience with EHRs? Any of you guys? Okay. How many of you that practiced with paper previously love your EHRs and couldn't imagine living without it? Any of you? Yeah, my hand doesn't go up either. I'm just being an example, actually. By the year 2000, the government and insurance industry realized there was a problem, that too many resources were being spent, aka money, that care had to be limited by digitizing the records to control costs. Now, of course, this is not something that doctors and healthcare facilities like hospitals and things would just do out of the goodness of their hearts as a huge monster government experiment. In the Bush administration, the federal government gave states money to send consultants to our offices, and maybe you remember that program around 2004. In New Jersey, it was called High Tech, where the Fed gave our state money, and the state gave private consultants the ability to come into our office to introduce us to EHR, and we got the, "Hi, I'm with the government, I'm here to help you" speech. And perhaps you're familiar with former President Reagan's interpretation of the most scary words in the English language. Having said all of that, they were trying to assess our readiness to embrace EHR because it was going to change the world, it was going to improve care, it was going to create efficiencies, it was going to aid communication, and it was going to provide care for less money, which is the bottom line in their plan. So the government came up with an elaborate scheme, and as part of the American Recovery and Reinvestment Act of 2009, it created the High Tech Act, which was finalized in 2010. So you know how the government works. They create something and then they create all the rules for it later. But here's the general idea. And then they started advertising, "It's time to get connected," per the Office of National Coordinator for Health Information Technology. Begin participating in 2011 and 2012 to earn the maximum incentive of $44,000 for Medicare and $63,000 for Medicaid. And meaningful use stage 1 was born. All the government criteria and hoops for you to jump through to get the money to perform the huge data procurement experiment that government and insurance wants to do to limit their cost exposures. Now, it sounds like a lot of money. $44,000, that sounds pretty good. And $63,000 sounds even better, especially for people who are willing and able to take Medicaid. But I don't know a lot of private physicians who can participate because you can't pay your office staff a reasonable living wage and meet your expenses. Having said all that, they even went further. They say certified EHR technology. Now let me explain that because they didn't have a process when they said it, but they hired more consultants to certify EHRs per government criteria. Not for care criteria, not physicians' criteria, not patients' health criteria, but government criteria. Does it do A? Does it do B? Does it do C? And all the vendors had to pay to participate in that program, even though the government had to pay also to create that program. Certified EHR technology can help improve the quality of health outcomes and the efficiency of healthcare while providing privacy and security safeguards. It sounds like a grand promise. It sounds wonderful. Who in this room would be opposed to all of those things if they only were true? Now we're going to move on just briefly to stepping back to the dictionary. Perhaps some of you that are younger in the room, dictionary was a book with lots of words in it, definitions and things, but you can get a lot of this from the internet. It's kind of a huge giant dictionary of sorts. But I wanted to just go over a few quick definitions because the government creates doublespeak and they make different definitions for the words we're all accustomed to without the usual customary historical definitions. So privacy is defined as freedom from unauthorized intrusions, that is one's right to privacy, secrecy, or a private matter, secret. Also from the same book, we're talking about confidentiality, marked by intimacy or a willingness to confide, private or secret, as in confidential information, which patient information is. It's entrusted with confidences. That is to say, patients trust us to keep their privacy. In order for us to perform and help them with their health care, they have to be able to tell us anything. The next is the security definition: freedom from danger or safety, freedom from fear or anxiety of such, something given, deposited, or pledged to make certain fulfillment of an obligation or surety. It also can imply protection and matters taken to guard against espionage, sabotage, crime, attack, or escape. Very serious definitions here, ladies and gentlemen. Medical office patient privacy. Originally, it was an original trio of the three at the top left: patient, physician, and staff. It was very simple. The patient agreed to pay the physician agreed to participate with the patient and to help them better understand their health and make recommendations that the patient was free to accept or not accept. And the staff helped facilitate the whole transaction. And for the last 100 or so years, it has been eloquently written down in paper charts, which are secure and private, and history demonstrates that. But now, over the past several decades, other healthcare entities have gotten involved. That is to say, billing services or billing and coding people in your office, the government, the AMA who creates the billing and coding mess, the insurance companies who we're all being part of and working with in order to help provide patients with care. The state is involved. In New Jersey, there's a Department of Health to report to. There's New Jersey Department of Youth and Family Services. And then there's legal entities, lawyers, judges. Basically, anybody with a subpoena power has the power to get your health information as a patient and as a physician. And now the government is creating regional health information organizations and health information exchanges that live in the sky, that are subject to all kinds of anarchy. All of a sudden, privacy is eroding fast before our eyes. I'm sure you all have been HIPAA'd to death, but that's the Health Insurance Portability and Accountability Act of 1996. The provisions came into play in the early 2000s, and I'm sure you all remember them. Again, the privacy rule provides federal protections, as they describe it, for personal health information and gives patients an array of rights. So far, so good. Sounds wonderful. At the same time, the privacy rule is balanced that permits the disclosure of personal health information, which now they call PHI, just to depersonalize it. It's needed for patient care and other information purposes. And I don't know if any of you remembers the early days of HIPAA in private practice in the mid-2000s, where hospitals, labs, specialists couldn't communicate with you, their physician, for fear of the HIPAA police. Did you ever make a call to a specialist office or a hospital and say, hey, I'm just checking up on my patient. Here's their demographic information. Here's who I am. Here's the information that you have and can prove who I am. No, I'm sorry, we can't speak with you. We don't have HIPAA permission. So you couldn't do your job to coordinate care any longer. The security rule specifies administrative, physical, and technical safeguards to assure the confidentiality, integrity, and availability of electronic health information. Again, that sounds good. It also covers you, and as covered entities, yes, you. It also covers your business associates, the people you use for billing, everybody in your office, everybody between you and the insurance company, everybody that you use to transact your business, which is now quite complicated because we've gotten away from the original trio, patient, physician, and staff. The HIPAA security rule now makes us, by law, have new expensive staff-consuming tasks that are now mandatory. In fact, there was an article in Medical Economics this past month that it had a billing and coding person that had initials after her last name. I think there were 12 different sets of initials, and I'd never heard of any of them for degrees in billing and coding and I don't even know what. And she said, doctors, this is not optional. You must create these systems for the government and for insurance companies. It's unbelievable. People whose jobs didn't even exist. Had anybody heard of a HIPAA privacy officer 20 years ago? What's a HIPAA privacy officer? What about a CMIO? Well, it sounds good. Maybe I get CEO pay for my CMIO. Wouldn't that be nice? That's the medical information officer at a healthcare facility. Yet another layer between you and the patient. You have to perform risk analysis, administration safeguards, information access management, ongoing workforce training. And as a doctor in solo practice, not a day goes by when we don't have some sort of informal training session during patient care hours. Again, my tongue is firmly in my cheek when I say that, because oftentimes I'll be in a room with the patient and the front desk person will buzz me and say, hey doc, I know you're doing an examination, I'm sorry to bother you, but I'm logged out of the computer again. So welcome to the IT help desk. You have to have physical safeguards and technical safeguards. These cost in both time and money, and they're not proven to establish the goals of security and privacy. Now, the government cannot assure security or privacy. It's just an inaccurate statement. What they can assure are the topic of my slide: federal penalties for HIPAA violations. That's all they can do. They can't make it private, but they can fine you with civil money penalties. They can even put you in jail with criminal penalties if you have a HIPAA violation. The bad news is HIPAA violations are costly. They can cost you between $100 per violation to $50,000 per violation. What's the bright side? What's the good news? There's a calendar year cap of $1.5 million. So all of you small practices, don't worry. You just have the $1.5 million sitting around in a bank, in an escrow account perhaps for the government, so that they can take it when they rack audit you. Small practices will go out of business, and physicians can wind up in jail for up to 10 years. Imagine, for a mistake, 10 years, a good faith mistake. Government makes them all the time. So EHR reality, interesting story. I have a patient who came in and he said, you know what, I'm 40 years old, I have 3 children, I'd like to get a vasectomy. And I said, well, I'd be happy to refer you to a urologist. I wrote out a script. I gave him some names to choose from, gave him risks and benefits of the procedure, and sent him off on his way. A few months later, I got a lovely analog consult letter. Fabulous. It was on the urologist letterhead. It said the patient was seen, was counseled, came back to another visit, had the procedure, came back to a third visit, actually gave a sample, and he had no sperm in his sample, so the procedure was complete. It was a success. It was completed over the course of 3 visits. Thank you very much, doctor, for this referral. A month later, the patient came into my office, and I asked him, I said, how did it go? Was it everything I explained to you? How did you like the urologist? I mean, that's how I base my referrals, on what patients say and what I get back via consult letters. The patient looked at me and charged and said, I wouldn't let him touch me. You got anybody else? And I said, wait a second. I've got a letter that says you had a consultation, you had the procedure, and you had post-op follow-up care indicating the procedure was a success. He said, I just didn't like the guy. You got somebody else? Whoa. So while the patient was in the room, I took time from patient care and other patients. I called the urologist's office and I spoke with the office manager and I told her what had happened. I said, this man he had the consult, but he didn't have the procedure, he didn't have the post-op care, and your letter said he did. Oh, that was an EHR error. We're having difficulty with our EHR. Somebody must have hit the wrong button and said he had the procedure and things, and he had follow-up care, and now he's sterile, although he's none of those things. Well, I explained to the office manager and the physicians that were there that if they also erroneously, by accident of EHR, billed for the procedure, that is the F word in medicine. Yes, ladies and gentlemen, the F word, fraud. God, that sounded ominous. Let me say that again, fraud. Yeah, fines and jail. Okay, all right, all for hitting the wrong button. Very interesting. Very interesting. They went with a new EHR the next year, so hopefully they're not still experiencing the same problems, but they're probably having a host of others. EHR, the best case scenario. Remember that big money, $40,000 and even more? Well, the best case scenario, as demonstrated in Modern Health of March of 11, was $46,000 per physician cost to get the thing set up including services. So assuming miraculously somehow you've passed all 3 stages of meaningful use, which is the government's way of not paying for what they're asking for, that is to say, all of us sending them their data in the format that they wish to have so that they can bring down the costs of care. You can't even pay for it with all 3 levels. Now, again, we're part of the way through stage 2 criteria, and stage 3 hasn't even been thought about yet. It changes all established workflows. Everything you do in your office changes with EHR. Everything. How you approach the patient, how your staff approaches you, how your staff approaches the patient, your billing and coding, everything. All staff requires extensive and expensive ongoing training. And as I had mentioned, the doctor in solo practice becomes the IT help desk. Now, I like computers. I've liked them in my personal life since 1983 when I had an Atari 800 with 48K. I mean, I'm a pretty literate guy when it comes to computers. When it comes to do they enhance my office? No. Are they affordable in my office? No. Will they compromise privacy and security for my patient's data? Yes. And that was the wrong place for a yes. I would have liked the yes in the other 2 questions. So privacy risk, data breaches, and huge potential penalties are issues. Malfunctions causing time and money. And there is no ongoing revenue stream to pay this $46,000 a year for physicians past 2014. So assuming you met all 3 stages of criteria and you got the whole nut, 3 years from now, you're paying that, ladies and gentlemen. You're taking that from your bottom line. You're taking that away from your staff, your patient care, and everything you do at the office. Somehow, miraculously, you have to come up with the money now. It won't be the insurance companies, and it won't be the government any longer. In the Wall Street Journal at the bottom there, you can see a study looked for in January of 2011, but can't find much evidence of eHealth's benefits in the Wall Street Journal. The Wall Street Journal said, this isn't a really good economic bet, guys, not even looking at the possible health issues. Now, after 2014, that's when the government and Medicare is going to start their pay for performance, which is the words they used to use to describe quality reporting, which will be non-pay for arbitrarily designated non-performance by third-party entities and government. That's what pay for performance will turn into. I actually had a diabetic patient who had come in, and we were talking about her labs. And she came in and I asked her how was the nephrologist that I sent her to. And she said, well, I was sitting in the chair and he stared at his EHR the whole time. He had seen me several times before, but he found the computer screen quite interesting. And he typed and he looked at the labs and he said, we have to increase your insulin. We definitely have to increase your insulin. And she said, but doctor, I'm on pills. I'm not on insulin. And the doctor said, but we have to increase it. Maybe you need a pump. I don't know. Maybe we should go with more of the long-acting insulin with 3 daily shots. And she said, and she stood up and she went across the room to the doctor and she looked at the screen and the doctor said, oh my God, you're not a man. This is somebody else's chart. I'm so sorry. He pressed the wrong button, almost ordered insulin erroneously on the wrong patient. And with e-prescribing, it's that easy. Press the button and it's gone. Try to get it back. Apologetically try to get it back. EHRs were thought to generally improve health care through coordination of care and increased accuracy in diagnosis, but that's not what a study at the University of Florida finds in recent months. It may keep primary care physicians from properly recognizing and treating cases of depression because you're not looking at the patient, you're looking at the screen. And whether or not the EHR lives in your office or up in the sky, you have to access it through their one eye, that screen. So it takes your eyes off the ball. And ladies and gentlemen, we're going to get hit with many pitches because our eyes are not on the ball. Major glitch for digital health records. Wall Street Journal again, they're really doing their part, ladies and gentlemen, thanks to them. September 13th, 2012, they said savings promised by government and vendors of information technology are little more than hype. Guess what? The government and insurance industry and technology industry all stands to benefit. So they don't care who potentially they hurt, whether it's patients or physicians. That's really discouraging. That's really discouraging. I mean, it's the government carrot and stick. Here's the carrot, here's the carrot, here's the carrot. 3 years into it, no more carrot, stick. You haven't performed. We're not going to pay you any longer, and we're going to go after you years after you've already delivered the care. That happened. I had a patient with Medicare. Medicare sent me a letter and says, we want $100 back, Dr. Wax, from 6 years ago. I said, let me look at it. It was totally appropriate. I said, I'll provide all documentation. This $100 is the offices for services rendered. They said, you can't appeal this late. You can't appeal after 6 years. So you can come after me whenever you want, and I have a limited time to appeal from the date it was submitted, not from the date you come after me with erroneous false information. Welcome to the RAC audit, ladies and gentlemen. Welcome to the, and the government will swear RAC is where it's at. We made millions and millions of dollars back for the taxpayers and the people. And guess what? I'll bet a lot of it is erroneous and false because doctors can't rightfully appeal. Digital health privacy, question mark. Enter big data. As I was on the plane, I was reading up for today's talk, and according to a WellPoint insurance executive, EVP, Lori Beer, that was quoted in Fortune September 24th, again, that I was reading on the plane coming out here. You have a lot of things to do when you come on a plane from New Jersey. Having said all of that, she said they have data on 100 million people. Let's think about that. 100 million people. That's a huge amount of data, a huge amount of data. And she said, she went on to say, she had data on 34 million active member subscribers and 64 million previous members. So if you were ever a member of an insurance institution, they keep your data. It's not yours anymore. It's out there. They keep it. Will they use it against you? Will they use it to deny care? Will they use it to say pre-existing something or come up with a new word to use? Of course they will. She bragged that our health data warehouse is bigger than the Library of Congress. I'm worried now. This doesn't go away. It's like every picture you've ever put up on Facebook, they have the rights to. Hope there's nothing embarrassing about any of you on Facebook. Having said all of that, there's multiple citations here where data was stolen from laptop. Privacy was compromised. Massachusetts General Hospital a year ago had to pay $1 million settlement. Health records were stolen. Laptops were stolen. In fact, one of my favorites is an older one that got a little bit of press in New Jersey in 2008, Horizon Blue Cross Blue Shield of New Jersey, which is famous for pre-existing conditions. And if the current law says no pre-existing conditions, they're going to have to find some other way to deny care because that's just what they do right out of the box. A laptop with Social Security numbers and member information walked out with over 250,000 subscribers on it. Walked out of their building in Newark. Now, I don't know about any of you guys, but I've never seen a laptop walk. I mean, maybe the next Apple product, it'll walk, it'll talk, it'll make dinner for you, you know, but now we just have to settle for being extremely thin and be careful not to drop it. Having said all that, data breaches always spark worry. And in the health game, we're all new to data because we don't understand data. We've never really used data before much, except in an analog way, which has been always the art and science of medicine. And it has worked. It has worked, and it has moved forward out of the dark ages to where we are. But what's going to happen now? I don't know if all of you remember, most of you probably have a MasterCard or Visa in your pocket, but back in March of this year, a little-known company in Atlanta that does a lot of card processing for the major companies with MasterCard and Visa exposed hundreds of thousands of people to fraud. What makes the government and people think medical data is any different? Or are we better than the big banks at keeping data? Well, here's the answer to that question: no. American Medical News, in brief, March of 2012, more than 90% of healthcare organizations, that is small healthcare organizations, that's 9 out of 10 people, have experienced a data breach. So almost everybody in this room has experienced a data breach. Almost every physician in America, by those standards, has experienced a data breach of some sort. That's dangerous. 35% of those people said that no one person in the organization had overall responsibility. So there was, not only did they have data breaches, but there was no one equipped to even deal with them when they had them. And almost 50% said negligent employees with access to data were the biggest threat. 2011 was a big year for breaches. So let's hear it for the data breaches. Everybody, let's hear it for data breaches. Thank you very much. They were up 97%. 97% over previous years. They've been keeping data since about 2008, 2009 was when that started. So they've gone up almost 100% over the previous year. In fact, Redspin's PHI breach analysis took the Department of Health and Human Services' own records to show that there were 385 data breaches of protected health information. 39% occurred on a laptop, 25% on a PC or server, 60% resulted from malicious intent as theft or hacking. 19 million patients' records were affected, and almost 60% involved a business associate. So it wasn't even necessarily the physician or the office, but someone you trust, like your billing company or the like. So not only, friends, are you on the hook for your own deeds, misdeeds, and mistakes, but for everyone you associate yourself with. Welcome to the government practice of medicine. And breaches affecting 500 or more individuals have to be reported and posted on the hhs.gov website. So you also get a great place in cyberspace to display yourself, your reward that you got. Because people are going to start looking there. It's going to be some major bad press when your patients find out that of your 3,000, 5,000, 10,000 records, you were exposed to a data breach. And now, do you have to give them all credit protection? What do you have to do? The government has yet to answer that. But they do have monetary penalties and jail time to help you feel better about the process. Laptops, email, desktops, network servers, none of them are safe. HHS's list was 21 million patients from 2009 to 2012. 21 million patients. 477 data breaches. Unbelievable. And the biggest offender, take a look at the third line here. TRICARE of the Department of Defense. Who is that? The US government. How many of us take TRICARE because we really want to help the people who help defend our liberty and our justice and our American system? Who here takes TRICARE? I take TRICARE proudly. I take TRICARE, and I deal with all of their mess just to be able to help the people that are involved in defending our liberties. TRICARE lost almost 5 million records when backup tapes went missing. 5 million records. Backup tapes they can't find. Unbelievable. Again, this is the government. Who do you report them to? This is another interesting one that actually came out recently in Becker's Spine Review. There was a practice of surgeons in Lake County, Illinois, who were held hostage by hackers that unencrypted their information, got into their server, and sent the doctors a ransom note. You will never get access to your records again unless you give us money. Can you believe that? Is that unadulterated chutzpah? Unbelievable. Unbelievable. Fortunately, the physicians were able to deactivate the server, but the outcome of the data breach was not disclosed. So we don't know whether any of the information actually got out. It's interesting because I first gave this talk earlier in the year for AAPS at a Freedom Town Hall for healthcare in New Jersey. And since I gave it, everybody's gotten into the act, including Diane Sawyer of ABC News. Maybe some of you saw that recently. She did a story that people are selling medical records online. How much would you bid for this medical record on eBay? Unbelievable. Unbelievable. And in the public eye. I had a patient who came to me from a retired doctor. He physically brought his paper chart to me. Physically brought it, and I thought that was a little unorthodox. It's not the way I'd have done it, but okay. Took his paper chart, brought it in, saw the patient, saw us a few times, decided his healthcare needs would be better serviced elsewhere, and he said, I'd like my chart back. And my staff told him, well, your chart has become part of your permanent record here that we have to hold by law for 7 years, so you can obtain a copy at a reasonably cheap price, which is the standard in New Jersey. Well, the patient wasn't satisfied by that and reported me to the Department of Civil Rights. Dr. Wax is purposely withholding medical records from me. Now, we weren't doing that. We were just going by office and privacy policy because we have to hold records. We offered to make him a copy at a reasonable cost. I think it was less than $20 for the whole shooting match. But he was upset. He reported me. I got a letter, and you get one of those letters from the government that raises the little hairs on the back of your neck that basically says, respond in 7 days. It doesn't even say or else, because you know the or else is there. It's just unspoken. Respond in 7 days. Okay. So I responded. I said, hey, this guy came. He brought us a chart unorthodoxly. We brought it. We made it part of his records. We said we'd be happy to make him a copy. There was a small fee, which is our standard office policy. It's for privacy. It's so we can be responsible for a responsible guardian of his health records for 7 years, even though he chose to get his care elsewhere. And do you know what the Office of Civil Rights did? They were communicating with me by a fax. They faxed me someone else's file. The Office of Civil Rights, let's hear it for the Office of Civil Rights. They faxed me someone else's file, so not only didn't they get what they came for, they also compromised other parties in doing so. Now, who do I report the Office of Civil Rights to? Mr. President, the Office of Civil Rights violated HIPAA, they should all go to jail. No, that's reserved for physicians, along with monetary penalties. Wait a second. That's just not right. Having said all of that, even the AMA News is saying that there's lots of legal risks of going paperless. I really like the graphic, because that's all of us. That's all of us there in that graphic. I don't know who the guy is with the hat behind him, but I don't like the fact that he's got a compact disc full of somebody else's data. You can have system breaches. There's even malpractice risk with e-discovery demands that we haven't even seen yet. Modification allegations and new tort claims. They create liability issues where none existed before, which is a very dangerous place to be. The New York ACLU says privacy protections are needed. Yes, we agree with you. They are needed. New York has invested $840 million to develop, remember I talked about those electronic health networks, RIOs and HIEs for medical records so that everybody can communicate together. Unfortunately, they can pose a threat to privacy. There should be an opt-out for patients and physicians, is what the New York ACLU says. And I wholeheartedly agree. If you want to go along with this madness, go along. But patients should be able to opt out. I don't want my stuff in the database. Physicians should be able to opt out. I don't want my stuff in the database. If they're going to go on with this nightmare, let them go on without me and without my patients. Fine. Having said all of that, you know, it sounded nice to have every physician, pharmacist, nurse, healthcare provider, medical assistant, and anybody who works at a healthcare facility have access to all of your medical records forever. Sounds promising. It does sound promising. However, a nurse in Walla Walla, Washington who works at a hospital could spy on her ex-husband's STD history in New York City from his teen years. Amazing, amazing the reach of these things. Or an insurance company in Los Angeles, California could spy on an insured's previous motor vehicle accident in Orlando, Florida. Neither party has any business with that information. We must safeguard our own information, safeguard our patients' information. So privacy, confidentiality, and security. I think Scott McNealy kind of had it right as the CEO of Sun Microsystems in 1999. You have zero privacy anyway. Get over it. Well, that sounds okay for maybe Facebook trivial stuff and for other things. However, for medical care, you have no privacy. Get over it. As far as I'm concerned, there can be no privacy, confidentiality, or security on the internet or web for any data. Once the data leaves your office, it belongs to others. So what's the most important in the practice of medicine? In fact, I took a page out of my daughter who, she's a young person, she texts all day long. EHR security and privacy, LOL. laughing out loud on that one. I was going to put the colon and the dash and the parenthesis to have like a smile or a wink, but I wasn't that technical. Perhaps I should have had her make up the slides. But what's important to you? Privacy, confidentiality, and security? Or insurance company reimbursement? Or government controls and compliance? The take-home message is, do you want your privates potentially made public? It is that simple. Consider your record-keeping method very carefully before leaping. This is an article that you've been provided with in your packet. Again, thanks to Jeremy for doing all the logistics. Data equals power. Patients and their physicians should own it. Whether it's on paper or electronic or wherever it is, it should be private and secure. Patients should have it, and physicians should have access to it. And I found that paper, which is ultimately recyclable, I mean, computers don't look good on landfills, but paper, after a while, degrades and becomes earth, which is kind of interesting because everybody says that it's not green and it's not friendly. But I find the opposite is true. We have never lost a paper chart. We have never had a paper chart adulterated. We have never had a theft of a paper chart in 10 years of practice. Unfortunately, 9 out of 10 of us will probably have data breaches this year. So I wanted to thank all of you. And I wanted to say I'll be back next year for Meaningful Use Stage 3, as well as The Revenge of ICD-10.